What is an ECV? External cephalic version is a procedure used to manually turn a baby from a breech or transverse. So this would be breech. Welcome, Shanice. This would be transverse into a head down position, which is this cephalic position, in preparation for a vaginal delivery. This procedure is typically performed after 36 weeks of pregnancy by an experienced healthcare provider or midwife using their hands on the outside of the belly to attempt to turn the baby. We're going to watch this video. It goes over how, when, why, and some of the risks that are involved.
The first procedure is called an external version. Sometimes it's also called an external cephalic version. During this procedure, the fetus is actually rotated from a breech presentation all the way to a cephalic presentation. The reason we do this procedure is because the cephalic presentation is the safest for vaginal delivery. And so when the fetus presents in any other position, we have an opportunity to try to rotate the fetus to cephalic. Now, it's not without risks that we do that, so it's important that we understand what those are. When we do the cephalic version, it can cause rupture of the membranes. It might lead to bleeding. It can cause fetal distress. Cletus the fetus doesn't always like to be moved around too much. And it can also cause someone to go into spontaneous labor. So how should the nurse prepare the client for the external version? First, due to the risks that we just talked about, it's very important that a consent form is signed. The second thing, to make sure that Cletus is doing okay before we start this procedure, the nurse should obtain a baseline non-stress test. Remember, we're looking for a reactive strip. Hopefully you remember back in antepartum when we talked about RhoGAM. It's the shot that we give for clients who are Rh negative to protect them from sensitization from an Rh positive fetus. So double check that chart and make sure that the client, if they're Rh negative, has received the RhoGAM. Also, it's important to make sure that an IV is established. In case there are any complications, labor starts, or we experience fetal distress, that access is going to be really important. Also, to calm the uterus down, because sometimes it's a little irritated even before we start this procedure, the provider may order a tocolytic to help calm things down. And finally, after the procedure is done, the nurse is going to again repeat that non-stress test and make sure that Cletus is A-okay before we move on.
So now we're going to watch a video of them actually doing the procedure. And we're going to be watching one in a medical environment first, and then we're going to watch one at home with a midwife second.
ECV technique in practice. The patient is placed with the bed tilted in 20 degrees head down position. A pillow is placed underneath the knees to relax the abdominal muscles. The partner is involved in the process by sitting at the foot end. We prefer a filled rather than an empty bladder, which makes it easier to lift the fetal breech from the maternal pelvis. An intravenous injection with tocolytics is administered. Warm ultrasound gel is applied to the mother's abdomen. 2 obstetricians perform the ECV as they are working as a team. The first obstetrician, focusing on the fetal head, identifies the fetal head. We ask the mother to relax and take a deep breath in and out. When exhaling, the second obstetrician, concentrating on the fetal breech, tries to lift the breech out of the pelvis. After succeeding, this obstetrician only focuses on having a firm hold on the baby's buttocks and stabilizing this new position. The first obstetrician, focusing on the fetal head, tries to manipulate the head with a pull movement in the turning direction. In order to prevent too much pressure on the fetus, these movements are consecutive rather than simultaneous. Simultaneously, the progression of the attempt and the fetal heart rate are monitored by ongoing ultrasound by a biometric nurse. When repeating these attempts by both obstetricians, one after the other, the baby will turn. After the baby has turned approximately 45 degrees, grip on the fetal head is lost in the pull movement, and a change of hands position into a push movement is made. The same principle applies to the fetal buttocks, where the other obstetrician also changes hands position from a pull movement into a push movement. Every attempt is registered by a study nurse who meticulously registers all events for scientific analysis.
All right, so that was the one in a medical environment. A few things that you can remind your clients if they are choosing to do this procedure is the pillow. So some care providers will forget about the pillow, and some of them will say, oh, the pillow is not really going to make a difference. It definitely makes our clients feel a lot more comfortable, and it helps to relax the uterus as well. So that's something that you guys can remember too. Reminding clients to empty their bladder before doing it. Usually right before the ECV in a hospital environment, they will do ultrasound assessment to make sure that baby's healthy. Sometimes that can be 20 minutes to an hour. It can be pretty long. And so they're already lying down for a while before actually doing the procedure. So you kind of want to remind them to, go empty their bladder and stay hydrated as well. Most of the time they'll be hooked up to an IV, but if your client doesn't want to have an IV, you want to make sure that she's very hydrated throughout the entire process. And breathing and relaxation. ECV is very scary for some moms because the likeliness of having an emergency C-section is higher if it doesn't go well and baby doesn't tolerate it well. And so the nerves that come along with that can just make her feel scared. And so really having her focus on her breathing, because if she's calm, baby's calm, it's more likely to increase the likeliness of a successful ECV. So like,
I have a question.
uh-huh.
Uh, what is the injection for?
Which one? The tocolytic?
Yeah, the video, they injected the woman first. So what is the injection for? And is it necessary?
So it's not necessary, but it can help. So the tocolytic is basically, it helps to relax the uterus. Some women might be a little bit tense before the procedure. And basically, the softer the uterus is, it's going to be easier for the doctors to basically add the pressure and do the movements. All right, so most women, they usually use the injection, but when women do it in a home birth or midwife environment, they actually don't use it. And they rely on just being relaxed during the procedure and hydrating before the procedure to do the process. So it's completely up to your clients. You can give them the benefits, the risks of using it, and let them go from there.
We're just going to spend some time talking to her. Hey, little one, bring your head on down into your mama's pelvis. Be a good baby now. Do what your mama says. Good girl. Good girl. Heart comes just below the belly button, please. Yeah, you help us. Take slow rest. It's my dad. That's it. Oh, there she is. I'm just gonna hold her here for a minute. You can totally have lots of tears. I know that was a big deal when you feel like nothing's hurting, right? Yeah. You slow rest. Okay, honey. All right, so I'm gonna pop it in here so she stays where she's supposed to for just a little bit longer. Baby, I did her thing. She's still hot. So she's now in vertex. Our head is just still a little high. So we're gonna get this whole getting off the table thing really slow. So that she just slowly is gonna settle into her pelvis. Okay. I feel proud of her. She is such a smart baby. She listens so well. You'd be very proud of that baby. She's a smart little one. She's like, oh, this is what you want? Okay, I'll do that. I'm gonna switch my hands with yours. So you're just gonna slip your finger in right under where mine is. I'm gonna put your other hand right here in a little bit. And then you're just gonna sort of just pressure and you just communicate with her about she's in the right place. That's right where she's supposed to be. And that she can even settle lower if she wants. Yeah, I'm sure she is. She's telling me all about it. It sounds great. She wasn't bothered at all by this.
Wasn't that so cool? What I loved about this one was, first and foremost, not all care providers are good at doing an ECV. So like even with some of the clients that we had last month, there was a doctor who was literally like, I can try to do it, but like I'm not good. Like she literally said she was not good at it. And the first attempt that she did it, She didn't even get the baby to move at all. She said the baby was lodged into her ribs, like around here. But like that's very uncommon. It's not to get the baby to move at all. And then there's other care providers who were really, really good at it. Literally within a few minutes, baby's head down. Of course, it has sometimes to do with mama, the size of the baby, the actual position of the baby. Sometimes if baby is like, some babies don't want to move. So every baby's different. Some babies are so comfortable in their position that they would consider them to be stubborn. I don't like to use the word stubborn, but even with all of these nudges, they will usually stay very put. And this is more common towards the ending of the pregnancy. So yeah, and then some babies, they're just ready and they're just excited to move. Another thing as well as this procedure is best done when baby's more calm. If baby's like awake and moving a lot, this procedure can possibly be a little bit more dangerous just because while she's moving baby's also moving at the same time. That's also something to consider as well. And then I just love to have this video. Did you guys hear her crying? She was so happy. And you can just imagine the emotions that come with this procedure because usually like when a baby's breech, sometimes a lot of people around them will make them feel like they have to have a C-section or their birth experience is like now going to ultimately change. And so they do feel like their options have become so limited. And especially depending on how long baby's been breeched, but like to have baby finally be head down, it's like a relief because it's like, okay, baby's head down. Now everything can go back to what their original plan was. So that's beautiful as well. The person who's holding the Doppler there, that would be a birth attendant or a birth assistant. So Terrell said, you've stated this can only be done at 36 towards 37 weeks. Yes. So okay, so babies don't usually go head down by 32 weeks, but from 32 to 37, they still have that grace period. And by 37 weeks, once baby's full term, baby should be head down. And so they're not going to do an ECV at 32, 33, 34 because baby can actually go head down on its own, if that makes sense. Akira said the midwife talked her through it. It was beautiful. Yes. And it was at the end. She was like, talk to baby and reaffirm to baby, like, it's okay to be in this position. And you can nestle down into the pelvis. So let's talk about the pelvis part. So the reason why they waited so long after the procedure is because sometimes after an ECV, the baby will go back. Like this is pretty common. So even after they do the flip, because baby was like so comfortable in the other position, sometimes they will go back to that position. So the goal is really to get baby to become low again in the pelvic area, like down here. And to do that, you want to help your clients with walking, squatting. So after the procedure, you basically want to get them moving, which we're going to talk about in the next few slides as well.
No, I just like that she did it with one hand. You know, she was just one person doing it while in the medical field, there was two people doing it.
Yeah. She was really good. Let's just put that out there. Not everybody can do that on their own with just one hand, but mom can actually help as well. So there's people who can do the procedure with mom helping as the second hand. The fact that she was able to do it on her own was pretty amazing as well. But there's also a benefit to having a second person doing it too, because they can hold the bum. And being able to hold the bum kind of makes the procedure a little bit easier because you're holding the bum while pushing the head, just makes it a bit easier, but she was able to do both. So I thought that was cool too. Alrighty, so your clients can do this with or without an epidural. It is her choice. The ECV can be done without an epidural. However, sending a client into a hospital environment and telling them that they want to do an ECV without an epidural is for some reason extremely shocking. They are very adamant on having an epidural during this procedure, which I personally don't like because it kind of gives them an excuse to make the procedure a little bit more rough. Without the epidural, they're more likely to be more gentle. And sometimes the epidural is lining them up for a C-section. So sometimes majority of the time when they schedule an ECV, they also schedule a C-section. And the reason why they do this is because they basically want like a slot open because they feel that it's very likely that baby won't tolerate the ECV well. So at least they'll have like a scheduled C-section. And they did this to one of my clients before. And I literally told her to leave. Like, thank goodness she left because she ended up having a home birth. And the midwife was able to flip her baby from breech to head down. But they were not okay with her doing it with the epidural. They already scheduled her a C-section. Like they were lining the events up so that basically they would do the ECV and they would be like, oh, it's not successful. Baby's not tolerating it well. And then transfer her to like a C-section environment. And because she already has the epidural in, it'd be easier for like that process to happen quickly. But she caught onto it very quickly and she left because your clients do have the right to leave. Even if it's against medical advice, sometimes they do have to sign an AMA, but at least they dodged a bullet, if that makes sense. All right, so with an epidural, they will usually feel less pain. But without an epidural, they'll feel more pressure and discomfort. So like you've seen when the midwife was like applying that pressure down. Johnny said, good, you don't leave. Yes, so we picked up on the little tricks over there. yeah, there is a lot more pressure. And so we just have to like prepare our clients. Like if they aren't going to do it with an epidural, like be prepared for the pressure, be prepared for the discomfort, and make sure you have your breathing down pat, and you can help them with that as well. All right, so let's talk about what makes a successful ECV. So several factors contribute to the success of an ECV. The baby size. So of course, the smaller the baby is, the easier it is for a baby to turn. Doesn't mean that a bigger baby can't be turned. We had an 8-pound, 12-ounce baby turned before. So that's not always the case, but they do say that is a little bit easier. It becomes more challenging to move them into the head down position when they are a little bit larger. Doulas, Johnny said midwife and birth attendant can only do ECV, not doula, correct. So doulas aren't supposed to do ECVs. There's a lot of doctors that also aren't supposed to do ECVs. It's really OBGYN or a midwife, depending on the midwife. So some midwives, they won't do ECVs at home. They will actually refer the patient to the hospital to do the ECV, and then they would continue care with them after. So it really depends on the midwife as well. Not every midwife does it. So if she doesn't want to do the ECV, she can do moxibustion. Have you guys heard of that before? Moxibustion? It's basically like what they do at the chiropractor office, and they use like a herb that they burn and they put it near the baby, and baby might not like the smell, so it encourages baby to rotate or go head down. So, oh, Amberly put it in the chat while I'm talking about. So there's that option. The other option is chiropractor adjustments. So by massaging the pelvic area and doing certain adjustments, there are chiropractors who are literally, they market their services for helping babies to flip from breech. So that's something else that they can do. I've had clients do that as well. What you can do is have them try that first before doing the ECV and like see if those other things will help first. And then the other thing is different positions. So even Amberly put in the chat, spinning babies, yes. So the different spinning baby positions can be used as well. Different inversions that can help babies to flip breech. The only thing about with these things, I recommend those as well, but it's not something that happens right away. So if like we're in a situation where baby's about to be delivered soon, she's like gonna have the baby, but baby's breech, of course the ECV is definitely better in a sense where you can do it faster. The positions to flip baby, like inversions, hands and knees, the spinning baby positions, those things you have to do consistently over time to help baby to rotate. Some people can get lucky, of course, but yeah. So Amberly put, I had a massage therapist who specialized in women, pregnant and newborn babies. Yes, that's another thing. There are special massages as well for this too. There is a few like massage therapists that will like do a full massage, and like they will do the massage until baby actually rotates. And they believe they have a really success rate at it. So that's something that they can do as well. Not every baby tolerates the massage well. I will say that. So that's another thing to be mindful of as well too. And then everybody says she does spinning babies, acupuncture, acupressure, and she has a very high success rate. Alrighty. And then Terrell said, statistically, out of 10 women, how many women need an ECV? 3% of babies are in a breech position after 36 weeks. So there we go. Pros. Increased chances of a vaginal delivery. You've seen the mom emotional and crying. A successful ECV can significantly reduce the need for a C-section, allowing for a straightforward vaginal birth. It's less invasive than a C-section, so oftentimes they might not even mention the ECV. Your clients can go in and they'll see that baby's in a breech position and they will automatically say C-section. This is when you can let them know, like, hey, no, she has options. Is it okay if we try the ECV procedure first and see if baby will flip? And they can actually do the ECV the same day before the C-section and see if baby will tolerate it well. It encourages a natural birth by getting the baby into an optimal head down position, and ECV increases the likeliness of a smoother labor process. So even if baby's breech, doesn't necessarily mean she can't deliver her baby vaginally. She can still deliver her baby vaginally. It's just that most care providers will say no, that she can't, because they're not skilled in it. Breech deliveries is not like commonly trained. They mostly train in head down position. So some doctors are just not comfortable with doing it because they are more comfortable with a C-section delivery because they pretty much do that almost every day. So just because somebody tells her, oh, she can't deliver vaginally because she's breech doesn't necessarily mean that she can. It just means that they can't. That makes sense. She can always switch care providers or find another OB who's more comfortable or more experienced with the breech position. Usually, doctors who've been working for a longer period of time are more comfortable with breech because they have a lot more experience. They've probably seen it a lot more often than somebody who's a little bit new. Alrighty, cons of an ECV. They're not always successful. So the success rate is about 50 to 60%. I knew that one, guys. And even if the baby turns, there's a chance the baby could flip back, especially if mom has more space. So if mom has like more space, more amniotic fluid, maybe baby's a little bit smaller and has more space in the uterus. Because baby has more space, baby can flip back, and they can literally flip back like right after the ECV is done, or they'll flip back when she goes home at that night, with about 5 to 8% of babies returning to breech after a successful ECV. So 5 to 8% of them will kind of flip back. To prevent them flipping back, we really want baby to get low and engage first. So the lower baby is in the pelvis, the less likely baby will flip back. If baby's engaged meaning at least at a 0 station, which we kind of went over before, but that's a whole different conversation for those who are new, but basically the lower they are in the vaginal area in the pelvis, the less likely they are to flip back. So right after the ECV, in a hospital environment, they like to monitor them for like another hour, sometimes even 2 hours. And if they're lying down for that long, they don't have gravity to work with them. So it's more likely baby's going to turn back. And that's why you can ask for we're going to talk about this in the next slide, but different ways of monitoring so that she can like get up and get moving and help baby to stay engaged. Possible discomfort. The procedure can be uncomfortable, especially without an epidural due to the pressure and risk of emergency C-section. In rare cases, if baby does not tolerate the procedure well, distress or changes in heart rate, a C-section may be necessary immediately. Many times, a C-section is scheduled for the same time as the ECV in cases of this situation. Can this procedure work for a twin birth? Janissa said. So usually there's one twin that's head down and one twin that's breech. I've never seen them do it in a twin birth before, but possibly. I can double check. But in a midwife environment, I'm sure after they deliver head down, they can do a flip for the breech, but it also depends if baby engaged. So an ECV can be done for twins, but it's very uncommon. The procedure is most common for single tone on one baby. The additional tips for success. So post ECV care. So after the procedure, using belly binders. So usually after the procedure, they can put binders on, which is like on the top of the belly. It's basically like a belly wrap at the top of the belly to help make the baby stay down. And then walking and squatting can help the baby settle into the pelvis and prevent flipping back. Monitoring after an ECV. So intermittent monitoring, of course, is better because then she can get up, she can move, she can walk around. Intermittent monitoring is like more common in a home birth or midwife environment. Usually in the hospital, the options are continuous monitoring or wireless monitoring. So continuous is when they have the pink and the blue straps. If they do that, just make it clear that we want her to be able to stand up after. So like, is it okay if she can stand up or she's like hooked up in a way where like as soon as the procedure is done, she can get up. They're still monitoring for the baby, but at least this way it's less likely for baby to flip. Or she can do the wireless monitoring, which is hooked up to her belly, and then she won't be hooked up to end cords. That gives her the ability to move around the entire room. And then timing near the labor. So performing the ECV closer to the labor, the onset of labor, or like even in early labor, it reduces the likelihood that the baby will flip back into breech.